Okay, we are recording. So this is chapter 38, Endocrine System, Function, and Assessment. So what are we going to learn? We're going to talk about what glands make up the endocrine system. We're going to talk a little bit about the function of the hormones in the endocrine system, how aging affects it, data collection for the endocrine system, care plans, and what kinds of treatments and nursing interventions. So just a little backwards review of A and P. When we look at the endocrine system, you've got the pineal gland, which is the one that's in charge of, if anybody remembers from Body Structure and Function, that's in charge of melatonin, which is what helps you sleep. Okay? You've got the hypothalamus and the pituitary, and I actually got this from Dr. Tish. If the pituitary gland is the dad and the hypothalamus is the mom, because the pituitary gland manages everything, but it can't do anything unless the mom says it's all right. Okay? You got your thyroid and parathyroids, your thymus, which is right in the center of the mediastinum. You have an adrenal gland over each of your kidneys. You have your pancreas. If you are female, your gonads are your ovaries, and if you are male, your gonads are your testicles. Okay? And all of these are part of the endocrine system, okay? I am not going to get into great detail, but I'm just going to kind of summarize the pituitary. The pituitary really is you could call him the father of the endocrine system, you can call him the king of the endocrine system. But if there's a problem with the pituitary gland, if there's a pituitary tumor, any problem with the pituitary gland will then affect all the others in turn. So it will be a whole cascade of problems, okay? And I'm just going to leave it at that. This goes into all the different hormones, okay? I only want to talk about a few, okay? And I'm just going to give an overview. So thyroid stimulating hormone, which is TSH, that's the hormone that comes from the brain, stimulates the thyroid gland to make thyroid hormone. So it's not thyroid hormone. People mistakenly think TSH is made by the thyroid. It's made by the brain, and it stimulates the thyroid gland, and it controls metabolism, how fast or how slow metabolism is. I'm not going into growth hormone, don't worry about it, or luteinizing hormone, or follicle stimulating hormone, not going into prolactin. Those hormones you're going to go over next term in maternal newborn, okay? Because they're the ones that stimulate your ovaries to pop an egg out every month. The prolactin has to do with the production of milk and the mammary glands, etc. So don't worry about them. So far we got TSH. And then we have adrenocorticotropic hormone, which stimulates the adrenal cortex to make steroids, corticosteroids, which is cortisol. So your body makes its own steroid. Why is that important? You'll understand when we get to diabetes insipidus and when we get to Addison's and Cushing's, okay? And then we've got, let's see, we're not going into the nerve fibers and all of that stuff, but I do want to talk about antidiuretic hormone, which is down here, ADH. Antidiuretic hormone is part of the system in the kidneys that is the renin, angiotensin 1, angiotensin 2, aldosterone, antidiuretic hormone. That hormone makes you hang on to fluid, right? Because if a diuretic makes you urinate, an antidiuretic makes you not urinate. And so it's also called vasopressin. And again, this will make sense when we get to that portion of the program when we talk about a treatment for diabetes insipidus and syndrome of inappropriate antidiuretic hormone. And then we have the thyroid gland. The thyroid gland is the only part of the endocrine system that you can actually palpate. And if you'd like to try, the way to do it is to hyperextend your neck. I usually take 3 fingers, my 3 middle digits, place them right below the trachea, and then swallow. As you swallow, you may be able to feel a little bit of your thyroid gland, which is all you should feel. If you feel a bulge, then your thyroid gland is swollen, and that is an indicator of hyperthyroidism. So that's important to know. So when you're doing a head-to-toe examination, if you're seeing signs and symptoms, you may want to ask the patient to hyperextend their neck and see if you can palpate their thyroid. Okay. Let's see, and those are the parathyroid glands. We'll talk about them later too, because they control calcitonin, which controls calcium. Okay, because you have calcium in your blood. That's the electrolyte in your bloodstream, serum calcium, and you have calcium in your bones. Calcitonin makes the decision as to whether it stays in your blood or leaves your blood and goes to your bone, leaves your bone and goes to your blood. It maintains balance of calcium. I am not getting into this, so delete.
No, you're not saying on it.
Okay. And then we have the pancreas, and the pancreas is very important. The pancreas is an endocrine gland and an exocrine gland. In this lecture, because we're doing endocrine, we're only going to talk about its functions from an endocrine perspective. And its functions from an endocrine perspective are the production of insulin and the production of glucagon. Okay? There are 3 types of cells: alpha cells, beta cells, and delta cells in the pancreas. Don't worry about delta. We're only going to talk about the alpha and the beta cells, glucagon, and insulin. When we get to diabetes mellitus, that's what it's all about. Okay? Okay. Let's see. I am not going to get into this just yet, because when we get to diabetes, I'm going to talk about how the pancreas responds when you eat foods containing carbohydrates, and I have a much better explanation. Now, what are the effects of aging on the endocrine system? Just like everything else, as we age, everything slows down a little bit and doesn't work as well as it typically did. So you will see a decrease in TSH typically, especially among older women, more so than men. And what happens is metabolic rate will slow down. And if your metabolic rate is slow, you'll be more fatigued and you'll gain weight, right? You'll see a decrease in the insulin secretion, which means that you can't tolerate as much sugar. Doesn't mean you're diabetic, but that's part of aging. Other people, not me. None of this stuff applies to me. All right, when we assess a patient, what are we assessing? We're always assessing, you know, the full personal history, family history, allergies, right? We're looking at their neuromuscular status, because when we look at it from an endocrine perspective, we're thinking about the hormones and how they affect things like calcium. And when you think calcium and magnesium, you think nerves. So that's why we're looking at the neuromuscular status. How are their reflexes? We're looking at their weight. Are they really thirsty all the time, or are they urinating very frequently? You'll see that has to do with diabetes. Are they, you know, tolerant or intolerant to really hot or really cold? In other words, if everybody in the room is comfortable, but I'm freezing, that's a sign, right? How are their moods? Are their moods labile? So I'm going to actually put that in here, the word labile, which you should know. Oops. Spell it correctly. Labile means up and down, right? So really happy, really sad, really happy, really sad, notwithstanding a psychiatric diagnosis. So in other words, do they seem a little moody? And how's their memory? Is their short-term memory getting a little fuzzy? That's not a normal part of aging. Memory loss is not part of aging. Something's going on. And then, of course, their family history is important. So these are all things when you're doing an endocrine assessment, you want to make sure that you are focusing on. And I'm going to say here, example given, calcium and how it affects nerves. Oops. So like reflexes. All right. And then physical assessment, the usual stuff. You're going to check vital signs, of course. You're going to check their weight, any changes in their skin. And when I say that, I'm talking about used to be oily, now it's super dry, right? Tremors, because again, when we're thinking about calcitonin, calcium, nervous system, right? That would be a problem. Their affect, okay? So I'm going to go over some words that, you know, you may or may not have heard before. when we say affect, we're talking about what is the look on their face. So their affect, the look on their face, should match their mood, right? So if I'm talking about something happy, I'm probably smiling. If I'm talking about something sad, I may be frowning. If I say to you, I just killed everybody in the neighborhood, that's a little scary because I'm smiling and that's a bad thing I'm talking about. So that's the affect. Affect is what does their face look like, right? Their expression. Expression on face. Exophthalmos. And don't tell me I can't pronounce it. Yes, you can. If I can, you can. Exophthalmos. Whenever you see that part of the word opthal, it's referring to the eyes. And exophthalmos is, ever see Wendy Williams? Boing! She got those eyes. Got them googly eyes. Exophthalmos is a sign of Graves' disease or hyperthyroidism. So that's important to take note of. And I'm going to put next to it googly eyes because I think that's funny. It makes me laugh. So fat pads. Let me explain what that means. With problems with steroids, which cortisol is your own corticosteroid in your body, overproduction of steroids will lead to accumulations of fat on the body, the trunk, and right at the base of the neck. It's called a buffalo hump. So it's not kyphosis. That's a curvature of the spine that you look like the Hunchback of Notre Dame. The fat pads are actually accumulations of fat, usually at the base of the neck, and they call that a buffalo hump. I'm going to put that here, and there are pictures later on. You can see base of neck equals buffalo hump. And yes, that's a medical term, I swear to God. And then the thyroid. Are you able to palpate it? Is there a goiter? Is the thyroid enlarged so it's sticking out? That's a problem. Okay. So these are all part of the physical assessment when we're looking at endocrine. And then let's talk about tests. Here are the tests that you need to know. These are blood tests now. So for the thyroid, you need to know TSH and T3 and T4. For anybody that's ever gone to an endocrinologist or ever seen a lab requisition from an endocrinologist, there are literally about 120 or 130 tests that we can do when it comes to endocrine. I'm telling you, endocrine is a little complicated, but we're just going to get right to the basics. So when you're assessing thyroid function, you're going to be looking at TSH and you're going to be looking at T3 and T4. And I'm actually going to put in here, I'm going to make this print a little bit smaller so that I can fit more on the page like this. And I'm going to say TSH elevated with hypothyroidism, okay? And the T3 and T4 are decreased with hypothyroid. This is going to make sense when we get to this part of the program, but just to help you understand. If the TSH is high, that means that their thyroid function is depressed, hypothyroid. If the TSH is low, then they have a hyperactive thyroid, and T3 and T4 are increased. So whatever their thyroid is doing, the TSH is the opposite, and the T3 and T4 are the same. So in other words, we've got elevated with hypothyroidism and decreased with hyper. And the T3 and the T4 are doing whatever the thyroid's doing. So if the thyroid is underactive hypo, then they're low. If the thyroid's hyperactive, then they're high. Elevated with hyperthyroidism. Okay. Don't worry about parathyroid tests. Just understand that when we're talking about the parathyroid, we are looking particularly at calcium. That is the big player with the parathyroid, okay? And we'll talk more about that later. We are not going over these tests at all. Yep, get rid of those. And then for diabetes mellitus, okay, pancreatic function tests, Here are the ones you need to know. Fasting blood glucose, normal, 60 to 100. You need to know that. And that's just checking the person's blood first thing in the morning when they have not eaten all night to see what their fasting sugar in their blood is. You can do it via a capillary stick, right? Or you can do a venipuncture, okay? And then the next thing is the oral glucose tolerance test. And anybody that has had a child, well, not anybody, but some of you may have had this done. You have to fast, and then you have to go into the lab, and they check your blood sugar with a finger stick, and then they give you this drink that tastes like syrup. It's super sweet. And you drink the drink. And then 2 hours later, they check your blood sugar again. And they're looking to see how fast your body, your pancreas, responded to all that sugar that you just drank. That's a glucose tolerance test. And I'm going to type in an explanation here of what it is, like I just explained to you. And 140 or less is normal. So that equals, and I hate the word normal, but I'm going to use it, right? And anything that's 141 to 200 is considered questionable. Probably repeat the test. And then if it's greater than 200, guess what? Diabetic. Diabetes. Okay? And then we have glycosylated hemoglobin, aka hemoglobin A1c. Okay? The word glycosylated means coated in sugar. So what we're looking at, we're not looking at your blood sugar. We're looking at your hemoglobin. And we're looking to see how much sugar is stuck on your hemoglobin. Okay? And what this does is it gives us an idea of what blood sugars have been over the past 90 days, give or take. Okay? So glycosylated hemoglobin, hemoglobin A1c, it is non-fasting. Okay? Normal for a person that's non-diabetic is 4 to 6%. If diabetic, we want less than 7%. And you need to know these numbers, okay? It's real important. So this test where we look at the amount of sugar stuck to hemoglobin. And it gives a 90-day window of average blood sugars. So if your sugars have been running high in the past 90 days, you've had incidences where the amount of sugar in your blood is super high. Every time that happens, a little bit of that sugar sticks to the hemoglobin and won't let go. And so looking at this tells us a lot. So if you're a diabetic, you come into the clinic and I say, how have your sugars been past 3 months? And you say, oh, great. They've been great. I've been watching my diet, taking my medicine. And then I look at the results and it's 14%. Either you lying or your medicine's not working, but your sugars have not been low. Okay? So that's the thing. So this helps us it helps us diagnose diabetes, and it'll help us to make a more effective treatment regimen for people that are diabetic as well. So you need to know those three: fasting blood glucose, 60 to 100, the oral glucose tolerance test, 140 or less normal, 141 to 200 questionable, greater than 200, diabetic, and then glycosylated hemoglobin, hemoglobin A1c. And little quick helpful hint, 4 to 6% for hemoglobin A1c is considered, within normal range. So if you were to ever get a question and they gave you one of the choices as being a hemoglobin A1c of like 1% or 2%, patient's dead. So that's not real. Okay. You can't be upright and have less than 4% because you need carbs. Okay? You need carbs. We need carbohydrates, and carbohydrates are sugars. There are complex sugars and simple sugars, but they're sugars nonetheless. And some of the sugar is going to stick to your red blood cells. It is, okay? So make sure that you know that. Now, here's a review question. What hormone increases water retention by the kidneys? Anybody remember?
Antidiuretic.
Yes, ma'am. All right, Marita. And that's important to know. Very good. Let's see. What hormone raises serum calcium levels?
Calcitonin.
Calcitonin.
That's right, girls. Nat, who else? Somebody else.
Stella.
Hey, Stella! That's the one. Did I tell you guys I love this group, by the way? I'm a mission next term. If you need me, holla! And which hormone? Oh, no. Yeah, here. Bye. Bye. And I am not even going to get into that. See that? We didn't really go over that yet, but excess of which hormone is associated with moon face and buffalo hump? So it's the corticosteroid that you make. Which one looks like a cortisol?
Cortisol.
Yeah, because it looks like corticosteroid, right?
Mm-hmm.
Right, so there you go. Good job. Ta-da! All right, I want to pause my recording. Come along with me and pause my recording. Okay, well now we're going to cover chapter 39. This is nursing care of patients with endocrine disorders, non-pancreatic. So in this chapter, we're going to talk about disorders of the thyroid gland and the adrenal glands and the parathyroid gland. We're not going to get into the pituitary, okay? So I'm going to highlight that. We're going to explain the pathophys. We're going to talk about the etiology, signs and symptoms of those endocrine disorders, right? So that you know what you're looking for and that you'll be able to answer questions. We are going to talk about therapeutic measures. In other words, how do we treat those disorders? Data do we collect? How we take care of those patients and how we evaluate the care that we have provided, okay? Pretty straightforward. And so endocrine disorders, it's all about the hormones, right? All about the hormones. If there's too much or too little hormone activity, you're going to have problems, okay? You're going to have problems. The book here, Production, Secretion, Tissue Sensitivity. So in other words, if you're making too little or too much, making too little or too much of a particular hormone, or if your tissues or and I'm going to put it this way, tissues or cells have become increasingly sensitive or decreasingly sensitive. So sensitivity is increased, and this is going to make sense in a minute, I promise, or decreased to those hormones. It's a problem. And these disorders can be primary or secondary. And remember, you're going to hear those terms a lot. Primary means this is what's wrong, and sometimes we just don't know why. Secondary means this is what's wrong because something else is wrong and it's causing this to be wrong. Okay? So that's primary versus secondary. And the first one we're going to talk about, antidiuretic hormone, and we're going to talk about diabetes insipidus. And when you see diabetes insipidus, I want your brain to just hear one thing. I want you to hear me go, waterfall! Diabetes insipidus, waterfall. Okay? With diabetes insipidus, if there's too little antidiuretic hormone, then you have SIADH. If you, and I'm sorry, boy, this is a terrible, terrible PowerPoint. So too little antidiuretic hormone, you have increased urine output. That's the waterfall, okay? And then this does not belong here. So let's do this. Because these are two separate diseases. Do you see what I mean about how it takes me so long to do things with this PowerPoint? because diabetes insipidus is waterfall. SIADH is the opposite. Okay? It's the opposite. SIADH is you have too much antidiuretic hormone, and when you have too much of it, you don't pee. Okay? So with diabetes insipidus, you're a waterfall. You pee and 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 you pee, and then you pee some more, even if you don't drink. You will pee to the point where your body will pull fluid from anywhere it can to make you pee. So you can pee yourself to death. Truth. Diabetes insipidus, waterfall. All you do is pee. SIADH, that is the opposite. You have too much antidiuretic hormone, so you're not peeing. You're retaining fluid. Okay? Retaining fluid. Let's do this. Decreased urine output. Fluid retention. Okay? So these are the two diseases. If you memorize this one, then you know that this one is the opposite. Okay? This one is the opposite. I'm going to go like this so that these are. There we go. Go over one more. And let's push that over one more. That looks better. Let's see. Okay. So now, pathophysiology. So with diabetes insipidus, you don't have enough ADH, okay? So that means that your kidneys do not reabsorb any water. So that means that all your kidneys do is go, all right, just let it go. They're like Elsa in Frozen. Let it go. Just pee, pee, pee. You will diurese anywhere between 3 and 15 liters of fluid a day. That's a lot of urine, okay? How do people get this disorder, this diabetes insipidus? Well, pituitary tumors are really the #1 cause, you know, so I'm going to put that little stars next to that. But if you're in a bad accident and you get a significant head trauma, can cause it. A surgery where we actually do damage to the pituitary, that can cause it. And certain drugs can cause it too, okay? Which really, I'm going to tell you the questions that you're going to be asked about diabetes insipidus. It's going to be, what's it about the insufficient ADH? What do we do to treat it? How do we diagnose it? Right? So they're the questions that you're going to get asked, and that's what we're going to go over. Diabetes insipidus, signs and symptoms, and I'm going to give you some words that you must know. Polyuria, you urinate constantly, right? So when we say poly means many urine. That means that all you do is pee. Polydipsia, that means that you are thirsty all the time. Just thirsty. You're thirsty because your body's getting rid of every bit of fluid you have. Nocturia, nocturne means at night. You urinate all night long. Just like Lionel Richie, all night long. Your urine is so dilute, it looks like water. Urine is not supposed to be clear, okay? Urine should have some color to it, okay? When urine is colorless or clear, that's bad. You're gonna be dehydrated. You can even go into hypovolemic shock, which means that you don't have enough fluid volume in your body, which can lead to a decreased level of consciousness and unconsciousness and death. So this can kill you, okay? This disease can kill you. How do we test it? The only 2 tests that you need to know, I'm going to tell you right now. When we do a urine analysis, we're going to look at the specific gravity of the urine, okay? And we're going to look at the water deprivation test. And that is a board question. They love to ask about the water deprivation test. I am going to delete those 2. So we'll work our way backwards. The water deprivation test means, so you go to a lab, and you are given nothing to drink. Anywhere from 3 to 8 hours. You don't need to know the time, but just know that you go to a lab, you can't drink anything, and they're measuring your urine output, measuring urine output, and the specific gravity of the urine. So people with diabetes insipidus, even though we give them nothing to drink, they just keep peeing. Okay. So their urine looks just like water. It's clear, colorless. The urine specific gravity, so 1.005. Okay. So anything that is greater than that, or I'm sorry, less than that, that's, you know, going to be what their urine will look like on a UA. And really, those are the two. The water deprivation test really is the most definitive diagnostic test, and that's the one the Board of Nursing loves to ask about. Okay. And if indeed the patient's in there for 3 to 8 hours and they don't drink anything and they just keep peeing and their urine is just clear, well, what do we do? What do we do? First thing we have to do is we have to replace the fluids that they're losing. Okay. So we will give them IV fluids, usually hypotonic IV fluids. We're not going to go into a hypophysectomy, but we are going to talk about the drug that we use to treat them, which is vasopressin, also known as desmopressin. And this is an ATI question and a question, okay? Vasopressin, desmopressin, is the man-made antidiuretic hormone. And so if you have diabetes insipidus, we're going to give you fluid replacement first so that you don't die. And then we're going to treat you by giving you man-made antidiuretic hormone, which is vasopressin, trade name desmopressin. Okay? It's very simple. Very, very simple. Okay? Here we go through some nursing diagnoses. Of course, deficient fluid volume, urine specific gravity. You know, what do we want? We want the patient's urine to be normal. We want there to be some color in it. We want the specific gravity between 1.005 and 1.03. We want their skin turgor to be elastic. In other words, when people start to become dehydrated, one of the things that you will see is something called tenting of the skin. And let me go over this with you really quickly because I want to make sure that you've got good information. I'm going to stop sharing my screen for a moment. When we are checking for skin turgor, for elasticity of skin, if it's an adult, I don't know if you've been told to do their hand. Has anyone ever been told that? Their hand? Anybody?
Yes.
Yeah. Never do that. Never do that.
No.
Never do that. And
Oh,
here's
sorry,
why.
I thought you saw me.
Here's why. Because your hand, what body part do you move the most? Your hands, right? And as you get older, you lose collagen in your skin. And so I am not dehydrated. Okay? But look, try to. That was kind of slow. You might say, oh my gosh, Miss Mary, are you dehydrated? No, I'm not, because that's not where you check. Okay? That's not going to give you an accurate representation of a patient's fluid status. When you're checking for skin turgor in an adult, you go to either the clavicle, right here, boom, boom, right back, right? Or you can go to the sternum, right here, boom, right back. If it's a baby, an infant, or a newborn, forehead. Make sure you know that. Those are board questions and predictor questions. Make sure you know that. Skin turgor should be checked on an adult at the clavicle or the sternum, on a baby, newborn, on the forehead. Okay? And if the skin tents, in other words, if it doesn't go right back, that's a sign of dehydration. Right? So people that have diabetes insipidus typically will have very poor skin turgor. Their skin will tent because they're getting dehydrated. So when we treat them, one of the goals is going to be for their skin turgor to be within normal limits, non-tenting skin. That tells us that our treatment's working. Make sense to everybody? Of course it does. Okay. All right. Back to this. So we want the patient's fluid balance to be maintained, right? All right. Then with SIADH, it's just the opposite. Instead of not enough ADH, you got too much. And they retain fluid, okay? They retain fluid. So they will blow up kind of like a balloon. They will have edema, not like with congestive heart failure. These people will have fluid retention everywhere, everywhere from head to toe, because they're not peeing, right? And why do people get this? Well, primarily nervous system disorders and cancer, especially gliomas and glioblastomas. Pituitary tumors can cause it too. And then there are some medications also that can stimulate the release of antidiuretic hormone in a way that's too excessive. But at any rate, if you remember that diabetes insipidus is not enough ADH and it's a waterfall, all they do is pee, then you know that this is the opposite. Okay? And the symptoms, signs and symptoms are going to be the opposite. They say weight gain without edema. It's not edema that is noticeable like pitting edema is with congestive heart failure, like I said. So it is generalized fluid retention from head to toe. Okay. Head to toe. Dilutional hyponatremia. Isn't that a fun word or a fun phrase? In other words, because of the fact that they're not urinating the way they should, you're going to find low sodium. And here's the way I explain this. If you have 2 glasses of water, and one glass has 4 ounces of water, and one glass has 8 ounces of water, if I put 1 teaspoon of salt into each of those glasses, the ratio of salt to water is going to be very different in the 8-ounce glass than it is in the 4-ounce glass. So with what's happening here is because they're not urinating, even though their sodium was normal, it's going to register low because they have just so much more fluid in them. Does that make sense to everybody? And that's a hard one to kind of get. Okay. I'm not going into serum osmolality. Their urine is now, instead of being colorless, it's going to be dark. It's going to be concentrated. Okay. Their specific gravity, 1.03. It's going to be, concentrated, even brown or tea colored, which is bad. I'll put here, I'll put that here. Okay. Dark, tea colored, or darker. I have seen urine that looks like mud, and that's not a lie, like really dark. And muscle cramps, muscle weakness, and they can even retain fluid. This is called cerebral edema. They can retain fluid in their brain, which can cause increased intracranial pressure and can cause them to have seizures and to die. Somebody, all right, hold on, wait a minute. All right, back to this again. So you've got SIADH and diabetes insipidus. Like I said, my advice to you would be memorize diabetes insipidus. Waterfall! And then no, SIADH is the exact opposite. The treatment for diabetes insipidus, vasopressin, desmopressin. Well, what's the treatment for SIADH, you might ask? And I'd say, well, that's a very good question. Let's see, when we look at the diagnostic tests, basically you're looking at their serum and urine sodium, and we're looking at what's the cause, because SIADH, something is triggering that to happen. But now let's look at therapeutic interventions. Okay? How do we treat it? And I'm going to eliminate some of this stuff because I'm going to tell you right now, we are either going to eliminate the cause if we can. So in other words, if there's a pituitary tumor, right? Well, get rid of the tumor, we solve the problem, right? We're going to give them a hypertonic solution, right? Because we need them to get rid of fluid. And basically, I'm going to get rid of this one. We're going to give them diuretics. The book says, furosemide, but just diuretics. Furosemide is typically the one that we give unless it's contraindicated. We've got to get rid of the fluid, right? We got to get rid of the excess fluid, and it's really that simple. And that's those two. And there are some nursing diagnoses. I am not doing deficiency of growth hormone, because no one will ever ask you about it. I'm not doing acromegaly because, I mean, it's fun to look at, but no one will ever ask you about it. So I'm not doing removal of the pituitary. It's very rare and very unusual. But let's go to thyroid, because you guys have lots of questions about thyroid, because that's a common issue. When we talk about thyroid hormone imbalance, you are either hypo or you're hyper. So hypothyroidism, I want you to remember low and slow, okay? And hyperthyroidism, I want you to remember high and fast. See how easy that is? Low and slow, or high and fast, okay? Because your thyroid hormones control your metabolic rate. And if your thyroid is working in underdrive too slowly, then everything is going to be slow. Everything is going to be slow. And when I say everything, I mean everything. I'm going to actually pause this sharing for a minute, because what I'm going to do is I'm going to pull up my cheat sheet, which is excellent. And I'm going to insert this cheat sheet into this PowerPoint. There it is. And cheat sheets. And let's find it. See how many cheat sheets I have? And this is just one folder. There it is. This is going to make life easy peasy, lemon squeezy. I'm pulling it up, and I'll share this screen with you as well as soon as it opens. It's a common. Well, that's not it. Let's get that one up. Okay, so this is one. And basically what I've done here is I put hypo on one side. Oh, wait, I'm paused. My bad. Let me unpause. Resume. There. So what I did with this is I put hypothyroidism on one side and hyper on the other side. Labs. With hypothyroidism, the TSH is high, but the T3 and T4 are low. The cause of this is unknown, and it's usually older women. I challenge you to go into a nursing home, any nursing home, and pull every female chart. You're going to find a whole lot of people on levothyroxine. Okay? You are. So the symptoms of hypothyroidism, low and slow, they are obese. And they don't eat that much, but they can't lose weight. They are tired all the time. They could sleep 14 hours and they're still exhausted. They are lethargic. They don't move around. They don't want to move. They don't feel like moving. Bradypnea, their breathing rate, respiratory rate slow. Bradycardia, their heart rate is slow. Hypotension, their blood pressure is low. Intolerance to cold, their temperature is low. Everything is low and slow, right? But then hyperthyroidism, now that's different. If the thyroid is overactive, your TSH will be low, but your T3 and T4 will be high. Typically caused by Graves' disease. Graves' disease is an autoimmune disorder. And again, when you ask us, well, what's the etiology of that? I'm going to say, it's idiopathic. We think it's autoimmune, but we're not sure. Okay? So with Graves' disease, the patient will have two things for sure. They will have a goiter, which is the swollen thyroid gland. And I'm going to pull up a picture in a minute of that. And they're going to have exophthalmos, which is what, guys?
Googly eyes.
That's right. It's the googly eyes. It's the Wendy Williams googly eyes. And everything is high and fast. They are super thin. They cannot sleep. Their blood pressure is high. Their respiratory rate's high. Their heart rate is high. They have intolerance to the heat. They're always hot, 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 all the time, okay? And for both of these, the testing is pretty much the same. I'm gonna look at your serum TSH and your T3 and your T4, okay? The treatment for an underactive or hypoactive thyroid is levothyroxine. That is the drug that you must know. And actually, I'm gonna put on here while I'm doing this, okay? Come on, giddy up. There we go. Oops, I don't want caps. So you're gonna take this drug first thing in the AM, okay? Oops, I'll fix this in a minute. On an empty stomach, full glass of water, and you're gonna wait, I'm putting this in capitals, wait 30 minutes before you take anything else or eat.
That's my problem. Waking up in the morning.
Everybody's problem. Okay, so that is what, you know, we need to know about that. Let me move this over. Oh, no, I don't want to move all of it. All right, I will fix this in a moment. Ta, 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 ta. Okay, and then I have another cheat sheet. Let me stop sharing for 1 minute and let me pull this up because the picture's worth 1,000 words, right? Let me find this. Here it is. This is the one I'm looking for because there are a lot more symptoms. Like, how does it affect the bowels? What do you think? How would it affect your bowels if your thyroid is low and slow? If you have hypothyroidism, what do you think would happen to your bowel movements?
Constipation.
That's right. Ding, 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 ding. That's right. Johnny, tell them what they've won. Constipation. Right? A lot of this, I promise you guys, is common sense. Gabish? You just got to think about it for a second, right? So hypothyroidism, you're going to be constipated. Hyperthyroidism, diarrhea, plop, plop. They're going to have diarrhea. Okay? I promise this picture is loading, so we will share the screen. Sounds like someone's snoring. I know that's not what it is. I know I don't put anybody to sleep.
No, it's my cat purring.
Oh my God, so loud. So cute. Here's the one. Hypothyroidism. Their hair is dry because there's no oil production because everything's slow. They even lose their hair, even their eyebrows. They're going to be depressed, puffy face, hoarseness, heartbeat is slow, sluggish movement, slow thinking, constipation, weight gain, brittle nails, broken sleep, arthritis, cold intolerance, la, la, la. Okay? Versus hyper. Hair loss, bulging eyes, breathlessness, enlarged thyroid, goiter, sweating, rapid heartbeat, weight loss, frequent bowel movements, warm, moist palms, soft nails, frequent. I like how they spelled itchiness. It looks like eye chines. All right, but they mean itchiness. Difficulty sleeping, muscle weakness, heat intolerance. Boy, there's a lot of typos on this one. And I liked it. Now I have to fix it. All right. High blood pressure, shaking, right? Trembling hands, infertility, irritability. That's even spelled wrong. Nervousness, minimal menstrual periods. So this is a testimony to two things. This is a great cheat sheet that kind of compares and contrasts, but I would never put my name on something before I spell checked it, right? So message to all of you, before you hand something in to anybody, always spell check it. Because what I'm saying to myself is, you know, this lazy person, they just put this up. Inspiring to never give up from hypothyroid free mama. I'm going to send her an email and say, Mama, check your spelling before you make cheat sheets. Check your spelling. Okay? So you guys understand, hyper, if you remember one, the other's the opposite,
Mhm.
right? And then tomorrow we're gonna go over, I can't do the drugs today because there's all the insulins and the anti-diabetics and propylthiouracil and methimazole and radioactive iodine. So we'll go over all the medications tomorrow, right? So getting back to our fun PowerPoint, shall we? We're almost done, if that's any consolation.
I got a question.
Okie dokie, shoot.
Do we have our final next week
Mhm.
for pharmacy one?
Okay, so no, because we still have, no, because school's not done. The final's the last week.
Next week is the last week.
Oh my God, wait a minute, yes. You have both your finals next week. Why am I thinking, you know why? Because the dates all got changed, that's why. Yes, yes. Yes,
Okay.
ma'am. Yeah, you have your final for nursing and farm.
Okay.
Yeah.
Miss
I
Mary,
was
are you
getting
gonna do
ready
like
to say, was there a week there I didn't know about?
Wait 1 second, hold on. Let me stop the recording for a second and we'll deal with these questions in a moment.
I was gonna say